Welcome to our podcast episode on diagnostic, prognostic, and predictive biomarkers for the treatment of breast cancer. I'm your host, Anna Christofides. Our guest for this episode is Dr. David Cescon, who is a medical oncologist and clinician scientist at the Princess Margaret Cancer Centre in Toronto, Ontario, where his clinical practice is devoted to the care of patients with breast cancer. Hope you enjoy it. Thank you so much, Dr. Cescon, for joining us today to discuss diagnostic and prognostic markers for the treatment of breast cancer. Thanks for coming.
Thanks, Anna, for having me to discuss this topic, which is becoming of increasing importance and relevance as we navigate the complexity of treatments that are emerging for the treatment of both early and advanced breast cancer.
Great. So to start, I wanted to ask, what was the first biomarker to be tested routinely as part of the care of patients who have breast cancer?
So great question. And this is one which goes back a long way. As you and your listeners probably understand, our standard management of breast cancer for many years has been focused on the traditional subtypes of ER positive, HER2 positive, and triple negative breast cancer. And the first biomarker, which was relevant to treatment decision-making, was hormone receptor expression, so estrogen receptor. And that dates back more than 40 years with the initial use of tamoxifen as endocrine treatment for breast cancer. Subsequently, with the approval of trastuzumab in the late 1990s, HER2 assessment began to be incorporated into standard management. So that's going on 25 years for HER2 testing as well.
Yeah, it's got a long history already, which is great. So, and just into the next question, I was wondering, what are the diagnostic and prognostic, as well as predictive biomarkers that we currently test for routinely as part of clinical practice in Canada? And where inside the treatment algorithm do we test for them?
So another great question, and one which is increasingly challenging to describe without some slides and diagrams, because we have an increasing number of biomarkers measured in an increasing number of ways that are relevant to the different stages of breast cancer. I think it's helpful perhaps to frame this in the way that we think of the tests, or in the way that we measure the tests. So that includes histologic-based biomarkers, like those immunohistochemistry tests that we talked about, as well as molecular diagnostics that can be measured in the tumor or in the blood. And then germline biomarkers, which are relevant as well for breast cancer, where we know that a familial breast cancer related to germline inheritance is also relevant for treatment decision-making. So if we go through each of those in turn, perhaps. So for histology, we talked already about the hormone receptors and the HER2 receptor. And of course, those are really the central paradigm for breast cancer biomarker testing, which are relevant at all stages of disease. So measurement of ER, PR, and HER2 in histology using immunohistochemistry, and in situ hybridization for HER2 positive should always be measured in breast cancer. And those guide both adjuvant therapies as well as are the critical underlying biomarkers that determine trajectories of treatment for metastatic or advanced breast cancer. The germline biomarkers, perhaps the next simplest to address. So germline mutations, specifically in BRCA1 and BRCA2, which have been recognized now again for decades as being important contributors to breast cancer risk, and therefore the surgical management of breast cancer, have now become increasingly important for drug-based therapy as well. So germline testing for BRCA1 and 2, which is often now done as part of a larger panel of genes which may be associated with inherited breast cancer, are measured in the blood. So these are germline variants that are inherited and contribute to breast cancer risk. So at the time of an initial diagnosis of breast cancer, these are relevant for surveillance strategies and potentially for surgery in someone who's affected by breast cancer who might choose to have prophylactic surgery or mastectomy as opposed to a lumpectomy at the time of their initial diagnosis. BRCA1 and BRCA2, though, are also relevant to systemic therapies because the presence of these mutations imparts a distinct biology in the tumors that arise in germline carriers of BRCA1 and 2. And those impart specific susceptibilities to certain treatments. And in particular there, we think of platinum-based chemotherapy in the metastatic setting where germline BRCA1 and 2 are relevant to chemotherapy selection. And more recently, the use of PARP inhibitors have been specifically developed for germline carriers of BRCA1 and BRCA2 in breast cancer. So PARP inhibitor olaparib for the treatment of metastatic disease is specifically investigated and approved in germline BRCA1 and 2 carriers. And more recently, the advent of the adjuvant use of olaparib in high-risk germline carriers of BRCA1, BRCA2, HER2-negative breast cancer has been approved for use. So over the last number of years, I think you can see there that the germline testing to identify carriers of BRCA1 and 2 in particular has really become a key biomarker for, again, all stages of breast cancer, which needs to be routinely assessed. Finally, going into other molecular tests, which would be measured in the tumor, we can think again of those that are relevant to early breast cancer and those that are relevant to advanced breast cancer. So for early breast cancer, specifically for ER-positive disease, we think of genomic assays that are relevant for chemotherapy decision-making. So these are tests like Oncotype DX or MammaPrint and others. And in advanced disease, we think of genetic alterations that might be relevant to treatments. We've already talked about the germline alterations in BRCA1 and BRCA2. There's also somatic alterations, a tumor-based alteration in PI3 kinase or the PIK3CA gene, which is the most commonly mutated oncogene in breast cancer, and in fact, all cancers. And this is relevant for the use of a PI3 kinase inhibitor, alpelisib, in combination with endocrine treatment, specifically for ER-positive, HER2-negative breast cancer. So that's a relevant biomarker in that subset as well. The additional histologic biomarkers that go along with ER, PR, and HER2 that we talked about that have relevance in either advanced disease or early disease have also expanded. So in advanced disease, specifically in the triple-negative breast cancer subgroup, measurement of PD-L1, which is used to inform the use of immunotherapy for the first-line treatment of triple-negative breast cancer, is now a standard marker that should be assessed. We can talk about some of the complexities of that because it's not straightforward either. And for ER-positive high-risk early breast cancer, another histologic test, Ki67, which is a marker of the proliferative status of the tumor, is relevant for adjuvant decision-making with a CDK4/6 inhibitor, abemaciclib. So it's a long list. I think we'll have to talk through some of the details of those individually. But as you can see, we've come a long way from measuring ER, PR, and HER2 to inform breast cancer management.
Yes, it's amazing the progress that has been made and how many biomarkers there now are. And so how do clinicians, struggle with all of these different bits of information and use them to affect treatment decisions? And also, which ones do you consider to inform diagnosis or prognosis as opposed to predict treatment benefits? And do you routinely retest the biomarkers upon disease progression?
That's a packed question there. So Perhaps we can address the prognostic versus predictive aspect first and the way that that's important in biomarker testing. So, to recap those definitions, prognostic biomarkers are those that are associated with outcomes under standard treatment. So in early breast cancer, those would be things that are associated with a higher risk of recurrence. In metastatic disease, those would be things that are associated with the worse progression-free or overall survival. And prognostic biomarkers are obviously useful because they can help us, understand the risk that an individual's at for recurrence of an early breast cancer that's being treated. And we can then think of the intensity of a adjuvant therapy that might be worthwhile in that setting where we need to balance the risks and the benefits of a given therapy. The same thing could be extended to metastatic disease. Predictive biomarkers, on the other hand, are biomarkers that are specifically associated with benefit for a given therapy. And predictive biomarkers, therefore, are also very useful in helping to make sure that we get the right treatment to the right patient and avoid using therapies that are toxic or costly in patients who won't benefit, and ensure that the therapies that can help people are most precisely delivered to that group of people. So both of these type of biomarkers can guide our treatment, particularly in the adjuvant setting. And in many cases, our biomarkers are both prognostic and predictive. So HER2, for example, is the biomarker that is both prognostic in patients who did not receive HER2-targeted therapies and predictive, because historically HER2-positive breast cancers had an exceedingly bad prognosis with a higher risk of recurrence. And HER2 also denotes the subgroup of tumors which specifically benefit from HER2-directed therapy. So this is sort of an ideal biomarker from the standpoint of treatment delivery because it allows us to identify a high-risk population, and it provides us with an effective treatment that we can specifically deliver to that population. So some of those other biomarkers that we talked about have different sort of components of prognostic or predictive effect. In the adjuvant setting, I would say that the prognostic effects of the biomarkers, as well as their predictive effects, are especially important because of that risk benefit and making sure that we're getting maximal yield on the costs and the toxicity of therapies. Whereas in the metastatic setting, probably most of our biomarkers are really focused on the predictive aspects, i.e., identifying that subgroup of patients who will specifically benefit from a therapy where we know that they have incurable or metastatic disease. I think you also asked about routinely retesting biomarkers at disease progression. And this is certainly an important, general theme in biomarker testing in breast cancer is that we know that some of these biomarkers can change over time. Historically, we've thought about ER, PR, and HER2 in that way, and it's been well characterized what the degree of change that can be observed in some of those markers. Some of that's related to probably natural tumor evolution or selection of more aggressive clones of cells that end up recurring. And part of it is likely influenced by the therapies that we deliver, the intervening therapies that we deliver to try and prevent recurrence. And so understanding what the nature of recurrent disease is versus the primary disease is important so that we can best deliver the most effective therapies guided by those biomarkers in the metastatic setting. So I think as a general rule, repeating biomarker assessments at the time of recurrent disease is relevant. Repeating biomarker testing at various intervals along the metastatic trajectory may also be relevant as well. I think it's hard to make a blanket statement about that, where often the rationale for reassessment will be driven by what treatments are potentially available and how has the patient responded to the most recent courses of therapy that were delivered, with the understanding that a particular biomarker was either present or absent. So for all of those biomarkers that we talked about off the start that are relevant either to metastatic disease or to early breast cancer, I think we're fortunate that we have very good guidelines that help to break down each of those treatment paths, which again are largely determined by the treatment setting, early breast cancer versus metastatic breast cancer. And secondly, stratified by that ER, PR, and HER2, where each of the traditional breast cancer subtypes has specific biomarkers that would then substratify the treatment approaches and relevant potential therapies.
That's great. A very complex area for sure. And so thinking about all the complexity of these various biomarkers, when it comes down to which treatments are actually currently available, which ones require biomarker testing?
So I'll speak here from a Canadian context, obviously, because some approvals for different therapies are different in Canada versus the US or other jurisdictions. And I won't speak specifically to funding of therapies. We recognize that funding of therapies differs across jurisdictions in Canada based on both public availability as well as the presence or absence of private drug coverage, which is specifically relevant or particularly relevant for oral therapies, which are not covered by many provincial drug plans. So if we go back to that, the standard therapies that we think about as the backbone of ER, HER2 and triple negative subtypes in the early breast cancer setting that require biomarkers are endocrine treatment for ER positive disease. And fortunately, those are routinely available. So drugs like tamoxifen or aromatase inhibitors. For HER2 positive disease, again, HER2 testing to define HER2 overexpressing or amplified breast cancer, HER2 positive breast cancer, as we've historically known it, is necessary to guide the use of HER2 targeted therapies in the early breast cancer setting. So that includes trastuzumab as well as pertuzumab for neoadjuvant therapy, and TDM1 and pertuzumab for adjuvant therapy. The newer therapies that have biomarker testing involved for early breast cancer include the PARP inhibitors that we talked about. So PARP inhibitors as adjuvant therapy for early breast cancer require biomarker testing for germline BRCA1 and BRCA2. Again, this is specifically relevant to HER2 negative breast cancer and is specifically relevant for patients with high risk disease, so anatomically high risk disease. So that's not to say that it's necessary for treatment decision making for every patient, because olaparib is only indicated in patients with high clinical risk disease. The same applies for abemaciclib, where Ki67 is relevant as adjuvant therapy here for ER positive HER2 negative disease that's clinically high risk based on anatomy. The one targeted therapy that we use in early breast cancer in the curative setting that's been recently approved in Canada, which is pembrolizumab. So pembrolizumab is immunotherapy that we now use in the neoadjuvant and adjuvant setting for patients with high-risk triple-negative breast cancer. This is an example of a new therapy that actually does not require a biomarker, where PD-L1, a biomarker which is relevant to the metastatic setting, is not necessary to guide the application of pembrolizumab for early breast cancer. So that's early breast cancer. In metastatic breast cancer, the therapies that require additional biomarkers beyond ER, PR, and HER2 include pembrolizumab and atezolizumab for advanced triple-negative breast cancer, so here relevant to a specific subset. And PD-L1 testing is necessary to identify the population of patients who can benefit from those immune checkpoint blocking therapies in combination with chemotherapy. We could talk about the specifics of the different PD-L1 testing, which may be relevant if you'd like to expand on that. And then germline BRCA for PARP inhibitors and PI3 kinase mutations for alpelisib in ER-positive breast cancer.
Well, that's great. It's a lot of different choices for patients, which I think is really exciting. And so thinking ahead to the future, I'm curious what the novel biomarkers and assays are that are emerging for the treatment of breast cancer.
So this is a field which is rapidly expanding, both related to new and emerging technologies that permit biomarker assessment, as well as new and emerging therapies, which are demonstrating clinical promise in breast cancer. So I think two biomarkers which are either here or are coming quickly are measurement of what we call HER2 low, as opposed to the HER2 negative and HER2 positive that we've historically thought about, and circulating tumor DNA. So perhaps to start first with HER2 low, because this is specifically relevant to one therapy, that's trastuzumab deruxtecan, an antibody drug conjugate, which has shown remarkable activity in HER2 positive breast cancer, but more recently has demonstrated superiority to chemotherapy for breast cancer that is not HER2 positive in the traditional sense, where HER2 positive disease was that which either overexpressed or had amplification of HER2. So in a study which has been reported recently and resulted in the US approval of trastuzumab deruxtecan, though not yet in Canada, patients with HER2 lower levels of expression of HER2 in their tumors, so this is measured by immunohistochemistry, HER2 called 1+ or 2+ without amplification of HER2, derived greater benefit from trastuzumab deruxtecan versus standard chemotherapy for pretreated metastatic breast cancer. That study was, again, in HER2 negative patients by the traditional sense, who had some expression of HER2 in their tumors. It included patients who were both ER positive and ER negative. So a subset of those patients were our traditional triple negative group, in that they did not have amplification or overexpression of HER2, and they did not express ER or PR, although they were a minority of the patients enrolled in that trial. So HER2 low is sort of most relevant today to the historical group that we would think of as being ER positive breast cancer. And this landscape is quickly evolving as that therapy is being evaluated in earlier lines of treatment, and indeed in groups of patients with even lower levels of HER2. So those patients who have called zero expression of HER2 by our standard immunohistochemistry assays in their tumor. So I think we can expect to see more developing in that arena over the coming years, and certainly many active clinical trials addressing this. The second biomarker that I raised, which I think is clearly having impact and will have further impact, is circulating tumor DNA. So circulating tumor DNA is DNA, which is shed from cancer cells, that can be detected in the bloodstream. And it can be detected in different ways and for different purposes. So I think it's important to think about measurement of ctDNA and ctDNA biomarkers in the sense of the fit for purposes of those assays and the clinical utility of those assays. So the simplest way to think about this is genotyping for biomarkers. So if a tumor genetic biomarker is relevant for therapy, and an example in breast cancer is that PI3 kinase mutation that we talked about, that can be detected in patients with metastatic disease with a ctDNA biomarker, so assessment of PIK3CA mutations in the blood. And the available assays for PI3 kinase mutant measurement have been demonstrated to be highly concordant with tissue sampling, although not every PI3 kinase mutation is picked up in the blood because not all tumors shed an adequate quantity of ctDNA to be picked up in the blood. So incorporating algorithms for tumor and blood-based testing are important for predictive biomarkers that arise in the tumor, so somatic mutations. And I think other solid tumor types like lung cancer have established very clear paradigms for this, where multiple targeted therapies that are matched to a given tumor genetic alteration are in standard use. So that's the genotyping aspect of ctDNA, which is relatively straightforward to think about. The other aspect of ctDNA is that it acts really as a marker of tumor burden, which may provide incremental information to our standard assessments like CT scans. And this is important in the setting of early breast cancer, where ctDNA has been demonstrated in breast cancer and other cancers to be able to, that it can be identified in early breast cancer in patients who do not have clinical evidence of disease, but who are then at extreme risk of a recurrence if ctDNA is detectable. So this is particularly relevant to breast cancer, which is a disease where we have a very strong adjuvant therapy paradigm. Many women, most women, in fact, with early breast cancer are treated with some type of adjuvant treatment. And we do that based on traditional risk assessment using biomarkers as well as anatomic risk. But we don't have anything to specifically measure or follow to assess the response to those treatments, or indeed to know who among that group of higher risk individuals really needs those treatments. So assays which may detect circulating tumor DNA in that setting where patients have completed their standard upfront treatment, surgery, radiation, perhaps completed some initial chemotherapy. It's been well demonstrated that those who have persistent ctDNA, so tumor-derived DNA that's present in the bloodstream, are at an extreme risk of recurrence. And that's a reflection of the fact that ctDNA that's detectable is detectable because there are some cancer cells that are still present and thus have the ability to grow out and recur into metastatic disease. In the metastatic setting, ctDNA, the burden of ctDNA, so the total amount that's detectable, is also a prognostic biomarker. More ctDNA is a reflection of a higher tumor burden and is associated with prognosis. Changes in ctDNA may provide early indicators of response to therapy. So in the future, in clinical trials, it may be possible to consider the use of dynamic changes in ctDNA to identify response or treatment failure earlier than we otherwise do. Whether that improves patient outcomes is something which is going to need to be evaluated in appropriately designed clinical trials, because it really forms a new paradigm for our treatment approaches. And measurement of additional biomarkers, particularly biomarkers or mutational biomarkers that may be relevant to treatment resistance, is a particular niche where ctDNA measurement may be useful, where we recognize that mutations can arise in tumors that drive resistance to standard therapies. So for ER-positive disease, think of ESR1 mutations that confer resistance to aromatase inhibitors, or a number of mutations that can confer resistance to the standard use of CDK4/6 inhibitors for ER-positive breast cancer. And it's challenging to have a routine biopsy assessment at the time of progression of disease in all patients. Tumor may not be accessible. That there's time taken, obviously, to schedule and perform a biopsy, risk of complications, et cetera. So circulating tumor DNA may provide a simple and straightforward way to quickly assess mutations that might be present at the time of the emergence of resistance on such therapies that could inform subsequent lines of therapy. And we're beginning to see some treatments emerge where that approach could be useful. ESR1 mutations in particular have been a focus for the development of next generation endocrine therapies for ER-positive breast cancer. So drugs like oral SERDs, where it appears that those tumors that have mutations in ESR1 may be those who are most likely to derive benefit from that type of therapy.
That's great. And that sort of leads nicely. And I think you've answered this in some part about, how these novel biomarkers and assays may impact treatment decisions in the future.
So again, I think if we go back to the early versus advanced breast cancer, so what I hope, and this would really represent a sea change in the way that we approach early breast cancer, but I hope that ctDNA in early breast cancer will enable us to better stratify our use of adjuvant therapies, such that instead of taking a treatment which we believe may be effective and testing it in a large group of patients where we know that a subset will recur and a large proportion will not, that the use of ctDNA to identify a group who have what's called molecular residual disease or minimal residual disease, those where ctDNA is detectable, but there's no evidence of metastatic disease, that those escalated interventions could be specifically directed to that group of patients, allowing us to, again, spare toxicity and deliver treatment in a much more precise way to those patients who really need it. Early days in the investigation of those strategies in breast cancer, although there are a number of trials that are ongoing and getting underway, but we've seen signals that that's likely to be the case in other diseases where there have been retrospective analyses of clinical trials looking at ctDNA as the determinants of benefit, and some recent prospective studies in colorectal cancer looking at ctDNA and how it might guide the use of adjuvant chemotherapy. Again, the important thing for early breast cancer is that the tests that are used to detect molecular residual disease, MRD, to inform those therapies has to be the right kind of test, and these have to be rigorously evaluated in clinical trials. It's not where one ctDNA test is interchangeable with another, where its intent or purpose might be completely different, like to identify a specific mutation which is relevant for a specific drug. So those tests operate completely differently and need to be specifically evaluated and applied in the settings where they're most fit for purpose. In metastatic breast cancer, I think the area where we're most likely to see impact of ctDNA assays in the near term is probably an ER-positive disease, where there's an increasing number of therapies that are relevant to second or third line therapy, where we've had a lot of clinical trials that have tested these strategies in unselected populations and have shown that in an unselected population, those therapies haven't been successful. And it's because we know that the biology of this disease is heterogeneous, and to be able to observe benefit of a strategy, it really has to be delivered to the right patient population. And so the use of ctDNA genotyping assays, for example, in the second or third line treatment of ER-positive breast cancer is and will be an active area of clinical investigation, and hopefully provide opportunities to develop new and effective biomarker-guided therapies in that setting.
Well, that's great. And so given the explosion in the number of biomarkers that we're seeing of recent years, what are some of the challenges in integrating the biomarkers and assays into clinical practice?
So this is a challenge which I think really demands very close collaboration between treating clinicians and our pathology colleagues who support the assessment of these biomarkers. And with an increasing number of biomarkers, you can imagine this can yield an ever-increasing cost of pathology or biomarker assessments, as well as an ever-increasing workload for the measurement of these biomarkers, where the pathologist is critical at really all stages of the biomarker assessment. And so making sure that we are requesting the biomarkers which are specifically relevant to a treatment decision that is going to be made, I think is necessary to ensure that we can continue to obtain those results in timeframes that are necessary for patient management. For example, we talked about measurement of PD-L1 for immunotherapy in first-line metastatic triple-negative breast cancer. First-line metastatic triple-negative breast cancer tends to be an aggressive disease, And when someone presents with metastatic disease, our goal and the patient's goal, obviously, is to be able to make treatment decisions and initiate their treatment without unnecessary delay. And so having both the standard biomarker assessments, if they have not been done historically, ER, PR, and HER2, and now assessment of PD-L1 status are necessary to best inform that management. So what that means is that this is another biomarker that must be measured. It's a challenging biomarker and pathology expertise is necessary. But the pathologist also needs to know what the planned therapy is. So there's different PD-L1 tests that are relevant to different anti-PD-1 or PD-L1 therapies. And not every patient is necessarily eligible for a immunotherapy for the first-line treatment of their metastatic breast cancer. And so making sure that those requests are made in situations where they will influence treatment, I think is one way that we can address that challenge. The standard pathology assessments, I think in general, have been well supported through initiatives with our pathology colleagues. I think a challenge as we think about some of these other molecular biomarkers or genomic biomarkers is access and funding for testing. So this is an area where assays for genomic profiling, so this is tests that assess many mutations, either in the tumor or in blood, are available and are widely used in certain jurisdictions where funding considerations are not at the top of the list. So in the US, for example, I think these things are widely used, where in Canada, access to genomic tests, so either tumor-based or blood-based, is limited because these are not funded assays in our current environment.
That's great. And hopefully some of those challenges can be relieved, I guess, with all of this explosion of the number of biomarkers and so on. And I know you're doing a lot of research in this area. So I'm wondering if you could share with us, the clinical trials that you're currently working on and how their results might impact clinical practice.
We have a number of clinical trials, like I said, and I'll touch on those in a minute. But first, perhaps just to address the comment you made about the access to the testing with the explosion of biomarkers. And this, I think, is actually an increasing challenge where we have this tension where there's more tests that are available that could be ordered, more costs associated with those tests, and in many cases, uncertainty about what the clinical utility of those is, where certainly more information can be gleaned, but understanding of whether it will impact clinical management and improve patient outcomes is in many cases less clear. So I think, we need to continue to advocate for the funding of therapies and biomarkers where there's proven utility, and understand that not every biomarker test or not every test will have clinical utility for all patients in all settings, so that we can use our resources most efficiently. In terms of clinical trials, however, these biomarkers can be very useful in identifying patients for clinical trials where such strategies are being evaluated and ultimately may demonstrate clinical utility that could support the routine integration of various biomarker tests. So I'm involved with a number of initiatives that are employing biomarkers in some of the settings that we've talked about. So one of these initiatives focused on metastatic disease for ER-positive breast cancer is looking at the application of circulating tumor DNA measurement for the delivery of therapy in patients who develop resistance to our standard, whose tumors develop resistance to our standard first-line endocrine and CDK4/6 inhibitor treatments. So this is, again, one of those areas where there's many drugs that are in development. There's many alterations that arise in tumors, though, do so at a relatively low frequency in the population. And so being able to pick those individuals who may benefit from a given therapy and assign them to that therapy such that the effectiveness of that drug can be specifically tested in the relevant patient population is an important next step to guiding the broader application of those biomarkers. So we have a clinical trial which is being conducted with the Canadian Cancer Trials Group, which will be launching soon at sites across Canada, where we will be able to take advantage of that type of blood-based tumor genotyping for therapy, drug matching, as well as looking at some of those other parameters of ctDNA, changes in the ctDNA prior to the development of treatment resistance, and changes in the ctDNA levels following the intervention with a new treatment, to understand how those might guide our future clinical development of new agents for metastatic ER-positive disease. The other area where I've had a lot of interest and ongoing activities is in what are sometimes called interception trials guided by ctDNA for early breast cancer. So these are the studies which I alluded to earlier, which a blood-based ctDNA test specifically designed to look for very small quantities or low levels of ctDNA are performed in patients who are otherwise completed or receiving their standard treatment for early breast cancer in a curative setting, and specifically then test interventions in patients where there is some detectable ctDNA. So those patients have already completed or already receiving their standard treatment, so that those who have no evidence of ctDNA do not receive an escalated intervention. And those who are ctDNA positive are then eligible for intervention. So we have an ongoing study, which we're participating in. It's being conducted globally, which is looking at ctDNA detection and intervention with a PARP inhibitor, actually, in patients with either triple negative breast cancer or BRCA-related breast cancer. So this is a bit different than the standard approved application of olaparib for germline BRCA-related breast cancer, which applies to high-risk patients independent of ctDNA and is done at a time point immediately after their standard treatment. Here, there's some monitoring of ctDNA that is undertaken, and if patients have a positive ctDNA test at a later time point, they may be eligible for those kind of interventions. So that's different than the way that historically our adjuvant therapies have been delivered. And working on a similar theme, we're just preparing to launch a study for HER2-positive breast cancer, which is being supported by the Ontario Institute of Cancer Research and some collaborators, where we're going to be, again, using a ctDNA-based assay to try and identify patients who are already on the standard treatment for high-risk HER2-positive breast cancer. And those who have detectable ctDNA would then be eligible for an escalated intervention to add another therapy onto the standard therapy. Again, trying to really identify the small proportion of patients who are at the greatest risk and direct these escalation interventions accordingly.
Wow, that's some really groundbreaking research that you're doing. And I really wanted to thank you so much, Dr. Cescon, for this. I'm sure it was very difficult to summarize such an exploding area like this, but you did so well. So I really appreciate that. And I think our listeners will really find this incredibly helpful. So thank you for joining us.
Okay, thanks, Anna. It was great to discuss it with you today.